me and you both are boots on the ground with psychiatrists. We're seeing patients every day. We see how it actually gets done. Most people do not have the resources to go get formal neuropsychiatric testing.
Ensuring that before, a psychiatrist prescribes a medication, that a diagnosis is accurate is critical. And certainly many people will come to me that have been on medications, have prior diagnoses, that, don't make sense or are not accurate.
What do you have to say as far as marijuana and cannabis and how that confounds the picture of diagnosing ADHD?
I think those advantages certainly do exist. And I think for many people with ADHD, there may be, very intangible ways of thinking outside of the box.
There's a lot of things in bipolar that can mimic ADHD. ADHD, bipolar, a lot of people, including my audience, they want an inside look into boots on the ground, into the life of being a psychiatrist, what goes into diagnosing and treating ADHD and bipolar, what are the similarities, how do we get them confused? Today, I'm bringing on a former colleague in residency at UCLA, Dr. Pat Baumgart.
Thank you so much.
Pat went to, Creighton for medical school. We met at UCLA for psychiatry residency. He has his fellowship in CNL. He'll tell you what that means over at USC. And now he is an outpatient psychiatrist at USC, boots on the ground, seeing patients all day. And I'm sure a lot of these patients come with complaints of either ADHD or bipolar. Pat, nice to have you.
Thank you, Dr. Ma. Dr. Mike, they call you these days, I hear.
That's exactly right.
Awesome.
Now, Pat, so tell us, first of all, what is a CNL fellowship? Just a couple words on that. And then what is it that you're doing every day? What does your life look like as far as work?
So CNL psychiatry is kind of a subspecialty of psychiatry that involves how we interface with the rest of kind of physicians, non-psychiatrist physicians, people like internal medicine doctors, surgeons, OBGYN, primary care physicians. And one reason that I really enjoyed it is it kind of helps kind of bridge us back to other specialties and kind of helps, prevent the chasm between medical health and mental health care. So, for example, CNL psychiatrists, they may work in hospitals alongside, various other types of physicians. They may work in the outpatient setting and liaise with primary care physicians, for example, but try to expand to essentially the whole net that we have for mental health treatment for individuals that may not otherwise, come to our attention, essentially.
Yeah, consult and liaison. So you guys are the psychiatrists in the hospital that when another team, like let's say a person is in the medical floor, you guys are the people that they call when there's also a psychiatric issue happening. Right. So you have a specific expertise in the crossover of biology and medicine with psychiatry.
That's correct.
Now, as far as the structure of today's podcast, first, I want to go over a brief description as far as what is ADHD, what is bipolar. After that, we'll dig into ADHD treatment. We'll get into a bit of the nitty-gritty with regards to medications used for ADHD. We will then do the same for bipolar disorder. And then we will talk about the overlap, how these two disorders can either be comorbid, meaning someone can have both, or they get confused for each other. Now, let's start with a brief overview of ADHD. So how do you conceptualize what is ADHD? And then the same question with regards to bipolar.
Of course. So definitely two diagnoses that I think a lot of people in lay culture, have some sort of understanding about. And there are certain misnomers about both of them. There's certain, aspects of both illnesses that can be confusing and can be challenging to determine from one another. So we understand ADHD and all, psychiatric illnesses perhaps is a mix of, biology usually a mix of temperament, a mix of early life experiences, and a mix of, perhaps the social environment around us. And traditionally, we think about ADHD as having kind of two main domains of symptoms: inattentive symptoms and hyperactive symptoms. In the past, ADHD was identified as something that was different if you had predominantly inattentive symptoms, as what's called ADD, or attention deficit disorder. So under the current DSM-5, kind of the Bible of psychiatry, if we can call it that, or perhaps the authority, in terms of diagnostic clarity, we think about both of those diagnoses being lumped together.
Yes, ADD no longer exists.
Right.
You now have ADHD, either inattentive type, hyperactive type, or combined. So the actual diagnosis of ADD no longer exists.
Right.
In the DSM-5, which is the book of diagnosing psychiatric disorders.
Right. So we think about hyperactive type and inattentive type. And some people have symptoms of both, which would be combined type. So inattentive symptoms, people may have difficulty starting tasks, difficulty prioritizing, difficulty meeting deadlines, difficulty kind of with general degree of organization. Certainly hyperactive symptoms include things like, fidgeting, for example, like in meetings or at work or in the classroom setting, or perhaps, having difficulty sitting still in quiet environments, perhaps repetitively interrupting other people, for example. So, many people may have symptoms of kind of both domains, especially as somebody, I work more with, adults. I don't see pediatric or, underage, young people, essentially. And there is this historical thought that many people will outgrow at least the hyperactive symptoms, or people outgrow ADHD. But certainly see, many adults that may have symptoms of both, predominantly perhaps inattentive, but certainly may still have hyperactive symptoms.
And we're going to get more into the details as far as diagnosing ADHD as we get to the ADHD section, but that's kind of a brief overview of ADHD. Now, what about bipolar? What is bipolar?
So bipolar is a mood disorder, traditionally. So I think many people that come to me, have a sense that bipolar disorder may be, something that is identified on the basis of irritability. And I think perhaps one of the overlapping factors, or the things that makes diagnostic clarity very challenging, is that many things cause irritability. Certainly poor sleep, insomnia cause irritability. Certainly anxiety disorders, people may be very irritable. Certainly personality disorders, people may be very chronically irritable. But traditionally, when we think about bipolar disorder, we think of an individual who has kind of episodic irritability, or irritability that perhaps is not always there, that varies with time. So typically individuals with bipolar disorder, they may have periods of what's called, kind of depressive spectrum symptoms, and they may have kind of more symptoms of what's known as mania or hypomania. And these are the kind of two poles, so people have periods where they have depressive symptoms for weeks at a time or months at a time. They may have periods where they're feeling well, and they may have periods of time where they're having these kind of manias or hypomanias.
Yes, it's bipolar, meaning that there are two poles. Now, normal human mood is also, it's like kind of a sine wave. People have their ups, people have their downs. But when patients have bipolar, the peaks are incredibly elevated to a problematic level, and the lows are at a problematic level and clinical, major depressions.
Correct.
Now, let's dive in first with ADHD. How do you go about diagnosing ADHD in your practice?
So ADHD is something that, certainly is a clinical assessment. So it's certainly, somebody who is, trained as a psychiatrist or a psychologist, is familiar with, many of these symptoms as are described in the DSM-5. The hallmark of any type of, disorder is that it causes some degree of psychosocial or functional impairment. It causes
Yes.
problems with your life. You know, it makes it difficult for you to do the things you need to do, whether it be, you know, in the relationships with other people, whether it be within, you know, your school-related responsibilities or your work-related responsibilities, whether it's, you know, getting into trouble with finances or the law. It creates some sort of problem in your life, and that is kind of paramount.
Yes.
Because I think, you know, there are many of us certainly who may have, you know, difficulty paying attention. We may have periods where we're very hyperactive. And to some degree, you know, that is certainly normative. But I guess the question is, you know, first and foremost from a clinical assessment, when does it cause a degree of impairment? And I think that's kind of the core, and that's the hallmark. I understand, you know, among mental health professionals, there may be some disagreement in terms of how do you make a formal diagnosis of ADHD. Some people very much want to see kind of more structured neuropsychological testing, in which essentially you go through a pretty standardized battery of questions, perhaps. That
Like a written test.
Like
included.
a written test, right?
Yeah.
Right. And some people will argue that, you know, it's a clinical diagnosis and something.
Well, what does that mean, a clinical diagnosis?
So a clinical diagnosis perhaps is something that is maybe more at the judgment or the discretion of a professional who meets with you and has a conversation about you or hears about your symptoms, rather than, you know, going through kind of a written formal test. You know, I don't necessarily believe that, you know, all people, fit in a box. Like some of these written tests try to allocate as either having an illness or not having an illness. And people are, you know, human behavior is incredibly complex. So I think the jury is still out to some degree, you know, in terms of, you know, how do you formally make the diagnosis? But I think first and foremost, it should be made on the basis of a mental health professional.
Yeah. Now, as far as getting diagnosed with ADHD, I think that the minority of people that get diagnosed with ADHD are going through formal neuropsychiatric testing, which is hours of paper to pen, interviews. Also, they're going to talk to your parents, people that knew you as a child. Certainly, that's the most comprehensive. But me and you both are boots on the ground with psychiatrists. We're seeing patients every day. We see how it actually gets done. Most people do not have the resources to go get formal neuropsychiatric testing. First of all, it's hard to find the person to do it. Second of all, it's very expensive. So the majority of ADHD diagnoses happen in the context of what Pat is describing as just a clinical evaluation. Me, Pat, whoever else, sitting there and asking them a slew of questions, mind you, also watching their behavior, and then coming to a diagnosis through question and answer.
Of course.
Now, what percentage of the patients that you either diagnose or rule out ADHD, do you do it from your own, you know, like a clinical assessment, like I just described, versus sending them to formal neuropsychiatric testing, paper and pen, filling out scales? What would you say?
I mean, it's variable, certainly. You know, I mean, I think there comes a degree of clinical suspicion. You know, so I would say always I would meet with somebody, you know, first. There would be a clinical evaluation and people are, you know, reporting these inattentive symptoms or these hyperactive symptoms. There are cases in which it seems, you know, very obvious and very clear and it's an easy diagnosis to make. There are times in which perhaps it is less obvious or less typical. There are times perhaps that, you know, as a clinician, you may even fear that people are falsifying their symptoms.
Yeah.
You know, so I
Which
think
we'll get to that.
Sure, absolutely. So I think there's a lot of variables that go into it. I think different psychiatrists have maybe a different threshold, you know, to making the diagnosis. I would argue that in individuals that, you know, come to me with, you know, very straightforward inattentive symptoms, hyperactive symptoms, those that, you know, have, you know, clear psychosocial impairment, you know, it's an easy diagnosis to make, you know, and I would say I would reserve a, you know, formal testing for probably, you know, a minority of those patients.
It's me too. I would say 85% of the time, after a 60 to 90 minute interview in which we just focused on evaluating for ADHD, 80% of the time, I'm confident in saying this patient has ADHD or this patient does not have ADHD.
Sure, agree.
The other 15, 20% of the time, I will refer out to formal neuropsychiatric testing, which is very valuable. But again, costly, time consuming. And for me, step 2, if I myself can't figure it out or if there's a borderline case. Now, going over the diagnostic criteria of ADHD. So Pat said something very valuable, not just in ADHD, but with all psychiatric diagnoses. One of the fundamental principles as to when it gets to a clinical level, meaning it's a disorder, is that when it causes a functional impairment in your personal life, your social life, your professional life. Now with ADHD specifically, if we go through the diagnostic criteria, what are you looking for? Now, for instance, if you look at the diagnostic criteria, you want evidence that this starts in childhood.
Correct.
You want evidence that there's impairments in at least 2 different domains, whether that's the family and home life and also the school life. But when you're diagnosing and evaluating for ADHD, what are you trying to suss out? What are you looking for? And how strictly do you adhere to DSM diagnostic criteria?
Yeah, I think it's variable. And again, I don't, follow the DSM tooth and nail. I think it's a good guide. And I think, you'll certainly encounter patients that have, different symptom burden. By that, I mean like a different number of symptoms. You'll certainly encounter patients that, have, significant or more significant challenges perhaps than others on the basis of, their symptoms. So it's variable. But, I think, looking for some narrative of some sort of hardship or difficulty or some sort of, roadblock dating back to early life is helpful.
What sort of roadblocks do you encounter that commonly lead you to believe that these issues might be secondary to an ADHD?
Oftentimes so I'm seeing adults again. So
18 plus.
18 plus. So oftentimes there's a narrative or report, given by the patient. And that can also be corroborated by, like a family member, like a parent, for example, who may be there to witness. Certainly, some degree of impairment, often will come up early in the school setting. So people will have, difficulty, sitting still in class in elementary school. They'll have difficulty kind of tolerating the academic requirements. They may do poorly on tests. They may, frequently get in trouble with teachers or principals. That's kind of the classical kind of pattern you may see kind of in the academic environment, in children. Usually as, an adult psychiatrist, there will be a report of that, and certainly parents, or, some source of, collateral resource can be very helpful in helping you, I identify, assuming that that's true. Usually when people come to me as adults, there is, clear challenges, in terms of maintaining some degree of higher academic, attainment. By that I mean, completing college, getting into college, getting in the rhythm of your career, finding, a meaningful job, attaining a sense of financial independence, financial responsibility, housing stability, being able, certainly to, develop interpersonal relationships, long-lasting interpersonal relationships with others that have a degree of responsibility and accountability. I look for kind of aspects of that, and I think that's more common kind of in people and perhaps in their 20s and their 30s, even into their 40s. But it does kind of become apparent, in that age group as people are trying to kind of figure out who they are and find their place in the world.
So what we'll get to is kind of the range of normal human inattention. But right now, I think it's going to be helpful for the audience. Let me go through the official formal criteria as far as diagnosing ADHD. Often fails to give close attention to details or makes careless mistakes in schoolwork, work, or other activities. Often has trouble holding attention on tasks or play activities. Often does not seem to listen when spoken to directly. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. Often has trouble organizing tasks and activities, often avoids, dislikes, or is reluctant to do tasks that require mental effort over a long period of time, often loses things necessary for tasks and activities, keys, wallet, cell phone, pencils, tools, books, easily distractible, and often forgetful in daily activities. Now, these are the inattentive symptoms. There's also hyperactive symptoms. You
Correct.
mentioned some of them. Inability to sit still, being fidgety. Now, question for you. Part of the diagnostic criteria is that some of these symptoms are present prior to the age of 12 years old, which then gets us to the question of, is adult onset ADHD a thing? So how much weight do you put into ADHD symptoms being not only present, but impairing as a child under 12 years old?
Well, I think this is something that is fairly controversial.
Yeah.
And I think there are many people that would agree that, especially if you're seeing somebody after that point in time, a failure to make a diagnosis or a failure for somebody to present to attention is a large confounder. I mean, there's plenty of people that, perhaps I'll see that, maybe have never seen a psychiatrist until they're 18 or 21 or 25 or 35 or 40, whatever it might be. Mm-hmm. And in that group, it can be very challenging because you can certainly, ask the patient, you can ask them, how did you do in school? What was your performance like? Did you have, difficulty, with your assignments? What kind of grades did you get?
Yes.
Did you require any sort of special education, things like a IEP or a 504 plan, for example? Or perhaps, in patients that are, very gifted intellectually, perhaps they may not struggle or they may not come to clinical attention until they're much older.
Yes.
For example, I have encountered people certainly that not until they've gotten to college or maybe in graduate degrees have they really struggled to the sense, because they were just so intellectually gifted, that their abilities were able to mask any sort of deficiency in terms of their productivity and their achievement.
Absolutely. That's hugely important, because just because you were able to make it successfully through elementary school, high school, college, does not necessarily rule out an ADHD. Because some people are gifted, they're intelligent enough, they have an IQ, or the support system around them, tutors, whatever, that they're able to compensate and still succeed academically through high school, college. So just because you've made it that far academically successfully with good grades does not necessarily rule out that you have ADHD. And like you were saying, a lot of times people present to me, patients, hey doc, the rubber's really hitting the road. I'm in a tough graduate program or at an Ivy League college or whatever, and I can't just get by on my raw intelligence, procrastinating, getting everything done last minute. So when things get more difficult and they can't rely on their intelligence or an IQ to compensate for the deficits of ADHD, that is often when they come to me and say, hey doc, there's something happening here. It's hard for me to organize, prioritize, keep track of time, focus, concentrate, get tasks initiated, follow through, complete them. So you agree that not necessarily, that just because you've had like a decently successful academic history, it doesn't rule out the fact that you might have ADHD.
I would agree with that wholeheartedly. And I know this is, again, I think a point that's fairly controversial, and I'm not a child psychiatrist, and correct me if I'm wrong, but I believe that earlier versions of the DSM had suggested that these symptoms came on earlier in childhood. Mm-hmm. And I think with time, with expert consensus, with, obviously the luxury of, more patient experiences, advances in science and literature, we've determined that, it's clear that these symptoms may persist longer than anticipated. And perhaps individuals who had symptoms that were functionally impairing by age 7 7, for example, were those that perhaps just had more significant symptom burden in childhood.
Yes.
And certainly, I mean, there may be cases in which, parents weren't familiar with, perhaps what this may have been historically, or people didn't, understand, perhaps how symptoms like these could cause impairment, and people never, came to clinical attention. It doesn't rule out anything, in my opinion.
So just because it was masked, compensated for, neglected, not noticed, can someone who did not have ADHD as a child develop ADHD as an adult?
I think that's a question that's also controversial. And I don't know where you sit on your thoughts on that. And I think, a lot of the people that I talk about, or that I speak with or converse with, or consult with, there is perhaps a degree of, skepticism. But, I would, favor on the side of, if you see symptoms now, if you see a degree of functional impairment now, if you have patients that are clearly, having difficulties with their interpersonal relationships, their work-related, responsibilities, their educational obligations, that, if it's functional impairing, I think it's worth treating.
I agree with you. It's definitely worth to treat. Where are we now? How are you doing now? What are your complaints and deficits now? ADHD is like a neurodevelopmental sort of disorder. It's the way that the brain works. As an adult, and especially with the way that society and technology is built and operates in our lives today, there are certainly a lot of factors that inhibit the development of the ability to sustain attention, aka focus and concentrate. So, can someone develop an attention and concentration deficit over time? I believe they can. Is that the classic neurodevelopmental ADHD that one might be born with? It might not be. But to Pat's point, what's sitting in front of us is someone who is coming with complaints of difficulties, deficits, that are having noticeable negative impacts in their ability to function at home, in the workplace, socially, and that needs to be respected and treated.
I would agree with that, and I think it's clear that, different people face different challenges throughout their lives. I think as far as, concentration deficits, it also is challenging to determine. I think from the lay perspective, a lot of people misattribute concentration deficits perhaps to ADHD. There are other things that can cause difficulties with such. Certainly, uncontrolled anxiety disorders can. Mm-hmm. Certainly, poor sleep habits can. Certainly, substance use issues can. Certainly, for example, chronic cannabis, people may have difficulty concentrating, prioritizing, other aspects. So I think it's important to speak with your physician about these symptoms. It's important to consider all options. It's important to, come to a clear and definitive diagnosis. And sometimes that's challenging, and sometimes that takes time. I certainly have many patients, that, are clearly, distressed by their symptoms. They're causing problems in their lives. They're causing problems in their relationships, or their work, or their school, or whatever. And a lot of people hope to, understand why those symptoms are, and it can be challenging and it can be confounding. Mm-hmm. And similarly, patients with bipolar disorder can have, difficulty with concentration, when they, have significant, symptom burden as well.
Yeah. Now that's hugely important. The confounding factors. It's our job to ask detailed, nuanced, incisive questions as to what exactly is interrupting your ability to focus or concentrate or organize or prioritize. Now, what Pat was talking about is the things that you have to rule out. If there's some sort of insomnia issue and you're not getting good sleep regularly, absolutely, that can negatively impact your ability to concentrate, perform cognitively, so on and so forth. if there is some sort of untreated clinical anxiety disorder, and every time I'm trying to concentrate, I have some sort of intrusive, ruminative, anxious thought disrupting that chain of thought and focus and concentration, this is the reason you need to see a psychiatrist to suss out what is ADHD or what is just anxiety, what is like your depression that leads to the difficulty motivating and starting a task or being future oriented enough from a depressive standpoint. Depressed patients don't have much hope for the future. They're not as future oriented. Does that look like the impulsivity and lack of future orientation that you see in ADHD? And notably, what you just said is there habitual cannabis use? Now, we have a psychiatrist here, expert in ADHD. What do you have to say as far as marijuana and cannabis and how that confounds the picture of diagnosing ADHD?
So more globally, certainly many people may have strong opinions about cannabis. People may come from, backgrounds or belief systems that cannabis is very dangerous or that cannabis is the panacea, for example, the cure-all. And I think the truth is probably somewhere in the middle, and as we move, nationally perhaps towards, legalization of cannabis, towards, rescheduling cannabis as a Schedule I where the federal government, identifies it as having no medical value, if that is, under consideration or continues to be in the scientific community, I think this will pose a lot more questions and a lot of challenges. I always encourage people, regardless if they're using cannabis, if they're not using cannabis, to be open, about discussing it with your doctor. A lot of people may come to the doctor with, the sense that if they, disclose substance use, that perhaps their doctor will be angry with them, or perhaps they won't want to help them, or they may feel strongly about them. And we acknowledge and understand that many people use cannabis. What I can say is, certainly regular habitual cannabis use, certainly does have, clear short-term cognitive deficits. People certainly can have difficulty with, concentration, initiation of tasks, completion of tasks,
working memory,
prioritization of your deadlines. So that always is a challenge. But we do understand that individuals with ADHD, if they are not perhaps treated with medications, they may be more predisposed or more likely to develop substance use disorders. And sometimes in the adult patient population, you will encounter situations where that's already true, where people may be using cannabis to, attempt to, mitigate their distress and attempt to, alleviate their irritability, their anxiety, their sleep-related problems. And I think it's always important to have an open-minded conversation and be honest, kind of bidirectionally, both the patient with the doctor and the doctor with the patient, about how the cannabis, may be, obscuring some of this, the diagnostic certainty or diagnostic clarity, and being open-minded to, working with your psychiatrist to, kind of troubleshoot and find, a treatment plan that works for you, not always, expecting that, stopping cannabis use is realistic, not always acknowledging that ongoing use of cannabis, may not be problematic. I think the truth probably lies somewhere in the middle.
Yeah. And, there's people that take a harsh stance. There are some psychiatrists that won't even evaluate someone for ADHD unless they have a negative piss test as far as like cannabis and marijuana. Right. Now, the stance I take is like what Pat was saying. Marijuana, cannabis, first of all, it can negatively impact your sleep quality. Second of all, it can have the negative consequences cognitively that Pat was talking about. It can cause significant issues with your working memory. Hey, I was just walking in this room to do that. What was I here doing for? What was I here to accomplish again? For me personally, unless there's a convincing childhood or history of ADHD, if I have an adult coming to me and we're questioning whether or not there's an ADHD in the picture, one of the first things I want to do is to stop the habitual cannabis use. Again, we'll get to the reasons why they're using it and so on and so forth, and if there's an anxiety or mood component. But we got to cut this habitual cannabis use out because it can mimic so many of the ADHD symptoms. I won't repeat everything you just said. Now, will you diagnose an ADHD in a circumstance like this if they have continued cannabis use without a compelling history as far as childhood of ADHD, or do you make them reduce or stop before you formally evaluate them?
I think in cases, that you're alluding to, where it's not clear.
Yeah.
There's not a clear, childhood history. Maybe you don't have, a parent or a teacher or, some record that is convincing, and people come to you at age 18 or 25 and they've been using cannabis habitually for years. I think it's a huge question mark, and it is something that, for diagnostic certainty is optimal. It is advisable, cut down on the cannabis use and let's see perhaps where you're at. I think that's an argument can certainly be made that that's appropriate, and that's good form.
Yeah.
And in cases where perhaps it is much more obvious or it is clear and people are using cannabis to mitigate these symptoms and the onset of the symptoms predates, the cannabis use, I might feel differently, but still I think I would have the same conversation with the patient, and hopefully a non-punitive way, in an open-minded way, in a way that aims for, more, just kind of education and awareness and building insight, is, letting the patient know that, listen, a lot of people that habitually use cannabis may have a lot of these similar symptoms. I wonder, is that something that's contributing to what you're experiencing?
Yeah. Non-punitive is important. What Pat was saying earlier, cannabis is just another type of psychotropic medication. If you're taking a psychotropic and mind-altering drug or medication on a daily basis, you have to tell your psychiatrist about this. We are working with the brain, the mind, the physiology, the psychopharmacology. We need to know what sort of chemical state your brain is in. And if you are using cannabis on a daily basis, you absolutely need to tell your psychiatrist about that.
I think that's really important. And yeah, again, many people may come, to these appointments, and they may be fearful for disclosing information, fearful that it will get them in trouble or that, it will ruin their alliance with their doctor. And I argue for the opposite. I always encourage people to, disclose all substance use openly, because so much substance use, whether it's ADHD or certainly bipolar disorder with the use of stimulants, it's a huge question mark, and allowing us all to be on the same page, I think, allows for a greater, degree of confidence in making an accurate diagnosis.
Yes.
And gives people, a better opportunity for, an evidence-based treatment plan and a greater likelihood that their symptoms will improve. So for all reasons, I encourage people to be open and honest with their substance use, and I think it's a very important part about the conversation.
Yeah, you use the word alliance. Again, you're entering into an alliance with your psychiatrist. It behooves you to get the best treatment, to be open and honest with your psychiatrist, and hopefully they foster a non-judgmental, atmosphere where you, and a trusting one, where you can bring these things up and discuss. Now, let's say, okay, I've diagnosed a patient with ADHD, whether it's inattentive combined, unspecified, whatever. Where do you go from here? What medications do you like to start with? We can get into nitty-gritty names, dosages. How do you first go about treating an inattentive ADHD, which I don't know about you, but the majority of the ADHD I see, the chief complaints are inattention, trouble with concentrating. Doc, I'm not too restless or hyperactive. I have a real time being on time, motivating, finishing tasks, and concentrating, especially if I'm uninterested. How do you treat? So
I think opening up kind of, the different pathways of treatment, I think, is important, and giving patients kind of the roadmap of the road, so to speak, is where I would start. So, we typically think of medication-based treatments and non-medication-based treatments. And both of those may be first-line agents. They may be things that are equally effective, but they are things that some people prefer medications, some people prefer non-medication therapies, and perhaps many people would do the best in kind of combined, combined method. So we think about medications, whether they are stimulants or non-stimulants, and we think of talk therapy, specifically cognitive behavioral therapy, as being perhaps, the best evidence-based methods for our patients.
So there is evidence-based therapies for ADHD.
That's correct.
Just because you have ADHD does not mean that the only answer is just medication.
That's correct.
There are non-pharmacological ways to improve symptoms of ADHD, including cognitive behavioral therapy, executive functioning coaching, and other non-pharmacological methods. So let's talk about the non-pharmacological methods, meaning non-medication ways to treat ADHD. And after that, we'll get into the medicines.
Sure. So cognitive behavioral therapy is talk therapy, a flavor of talk therapy, so to speak, or psychotherapy that essentially examines the relationship between thoughts, emotions, and our behaviors. It's something that is potentially useful in a wide range of different psychiatric illnesses or disorders, mood disorders such as major depressive disorder, bipolar disorder, anxiety disorders, and essentially gives patients, a sense of kind of introspection or insight or thoughts or skills training kind of into their own behaviors and how they impact their lives.
How can that target ADHD specifically? Like if I had a patient, hey, therapist, I'm here for CBT specifically oriented towards ADHD. What are they doing there?
Perhaps they can examine, things like, for example, procrastination, how, your symptoms, your inattentive symptoms, your hyperactive symptoms may lead to procrastination, how that procrastination may impact in, adverse outcomes, and essentially trying to trace the cord back to the wall, for example, and trying to understand, perhaps how I can change my own behavior, my own skills, or my own prioritization of tasks in order to kind of mitigate any sort of risk this may put me at or any sort of adverse outcome. So enabling patients to better understand perhaps their own behaviors and their own emotions and how that translates to perhaps these circumstances they find themselves in that may result in some sort of adverse outcome can be very helpful for many patients.
Yes, I've seen it. Yeah.
So that I think is kind of my understanding and kind of the hallmark of kind of the non-behavioral, side of things, and certainly something that, may last much longer than perhaps when you stop taking the stimulant or non-stimulant, that you can carry forward with your life, and certainly something that I think is, an integral part of any sort of, mental health treatment is talk therapy, moving for, skills training, behavioral changes, things that people can move forward with their lives and essentially work to hopefully, better their own, challenges and better their own experiences to give themselves more fulfilling lives.
Yes, I think it's very important to note that medication aside, if you have ADHD, you do not have to concede that this is how my brain works. This is how it's going to be. You can get involved in a therapist. You can analyze your own behavior. You can discover repetitive patterns that you might be falling into that are not serving you. You can find reasons why you're engaging in avoidance behavior, and growth and change, even with ADHD, is absolutely possible even without adding in a medication with good therapy. Now, if anybody needs a referral for a very good ADHD therapist, CBT therapist, or executive functioning coaching, we'll talk about I'm going to ask you what executive functioning means. Leave a comment. We'll help set you guys up. Now, executive functioning deficit. So in ADHD, there's trouble with concentration. There's trouble with time management. There can be trouble with impulsivity. There can be difficulty with looking at the future rather than just what's right in front of you. And there can be issues with executive functioning, What is executive functioning?
So we think of executive functioning perhaps as like the highest order of organization and cognition. Perhaps, the something as, humans that separates us from other primates, perhaps something that, separates us from other organisms. Our ability to, essentially consider, not only what's, physically in front of us, that is, the concept of future, the concept of, metaphysics, the concepts of, all these kind of intangible things around us, and really use all our skills to, prioritize tasks in front of us, really consider, things, that may be downstream effects of our behaviors and what we may do, and perhaps things that could affect, the future or the past, ruminating about the past, for example, rather than just what is physically in front of you and what is immediately problematic.
Yeah, and something I see a lot online and a lot of the audience asks me are the emotional aspects of ADHD, for instance, rejection sensitivity. Now, what are your thoughts as far as rejection sensitivity and ADHD?
I think many people with ADHD, they're certainly aware of their challenges that they face. They certainly, dating all the way back to childhood, for example, maybe, individuals that are brought to the attention of, not only teachers, but administrators. They may be under the scrutiny of their own parents. They may be, as they get older, under the scrutiny of, employers, colleagues. So I think many people have a sense of, when others bring their symptoms, we'll call them, their challenges, to the spotlight, especially if it's done publicly, people can react, in ways that, demonstrate how painful it may be to them.
Yes.
And certainly may, interact in a way that may seem, irritable or explosive or, it can cause a lot of interpersonal challenges in their relationships with other people, especially as adults, whether it be with spouses, whether it be with employers, with parents, for example. And I think this is, again, one of the huge confounders between ADHD and bipolar disorder is how does this kind of, predisposition perhaps to, irritability, having arguments, having outbursts, kind of characterized, by this, sensitivity towards, scrutiny.
Yes, and that sensitivity towards scrutiny. So as far as rejection sensitivity, the ADHD patient, and their self-esteem. So oftentimes you have this ADHD patient that growing up may have been in trouble at school. He can't sit still. He's always disruptive. He's always daydreaming. He's not doing well in school. And the scrutiny that they receive from their peers, their teachers, their family members, their parents, a lot of ADHD people then internalize the fact that something is wrong with me. There is something implicitly wrong with me. This has, and when you fall under that belief that there is something implicitly wrong with me, so much springs out of that. Oh, I'm unworthy of attachment. I'm unworthy of love. And their self-esteem suffers. Now, when someone has a low self-esteem or they feel like there's something implicitly wrong with them, there's something broken inside of me, and that has been validated by my teachers, my family, my peers, as they grow into adults and they try to form friendships or romantic attachments, they have to be vulnerable because, again, they're so scared that something is damaged within them that if they show this full side of them, it's going to be rejected like it has been my entire life. So they have such a sensitivity towards rejection because it validates their fear and what they have learned, that there is something wrong with them. So this is what I see is the seed that grows out this tree of rejection sensitivity, low self-esteem. I feel unlovable. There is something wrong with me. Shame. A lot of patients with this rejection sensitivity also harbor a lot of shame. Now, it's important for whoever listening that might relate to this that ADHD is nothing to be ashamed of. I personally believe that it is not some sort of deficiency or it's not some sort of disorder. It's just a certain way that your brain works that perhaps in society today, when you're a little kid and you're hyperactive, you got all this energy and you're impulsive, oh, I'm forced to just sit in a chair for 8 hours a day. Or as an adult, I'm just forced to sit in this chair sitting at this computer 8 hours a day. So to me, it just might not necessarily fit today's society and culture. But I believe that there's an entire side of ADHD that is a positive. It puts you ahead. So what do you think? Well, first of all, do you agree with that there are advantages of having ADHD? And if so, what do you think those are?
I think those advantages certainly do exist. And I think for many people with ADHD, there may be, very intangible ways of thinking outside of the box. For example, to use the analogy of, sitting in a cubicle for 8 hours a day and mindlessly, checking emails or going through, digital tasks. I think many people with ADHD may be able to fixate on, other types of tasks, creativity. People may be able to zone in, for example, on, a certain stimuli and see things in a meaningful way that others cannot, and, perhaps harness a sense of innovation or ingenuity. Mm-hmm. In ways that, perhaps, those that, can tolerate a classroom setting, for, 8 hours a day or sit in, a computer station, not ask any sort of questions or bring any sort of concerns to the table may not otherwise bring to the attention of humanity.
Yeah. And what you said is hugely important. So it's, for the audience listening, it's very important to realize that with ADHD, there's two sides of the coin. There's difficulty concentrating and focusing on a task, usually that may not feel rewarding or interesting or give you some sort of feeling, positive feeling. But on the other side of that coin, and what I look for and evaluate when I'm looking for ADHD is the ability to fixate, the hyperfixation and intense focus that ADHD patients can engage in can often be a superpower. Mind you, this is one way that ADHD people lose track of time and have difficulty being punctual, is ADHD patients have this superpower of hyperfixation that to me feels like it can be a major advantage.
Certainly.
Yeah. Now, how often do you look for that other side of the coin? The hyperfixation associated with having ADHD?
I think I see it in many of my patients. Many of my patients have already kind of harnessed those abilities. I see many people with ADHD in the arts, for example, individuals that are pursuing careers that are, creative or that, perhaps, require a sense of thinking outside of the box or innovation or challenging norms or perhaps, seeing the world or seeing things in different or new ways. And I think many of them, individuals, my patients that come to me in their 20s and 30s and 40s, tend to find themselves, pursuing interests that foster those.
I see a lot. Some of the most successful people I know are those that have ADHD that have put themselves in a context that really rewards the way their brain works. They have a ton of energy. They can attend to something in the moment and get fixated if it's interesting or rewarding. They can task switch. They can handle a lot of stimulation at one time. Their impulsivity leads to quick decision making. So ADHD can be used to someone's advantage to thrive.
Certainly. Now
let's get into treatments for ADHD. So you have an ADHD patient, clearly ADHD. Let's say the diagnosis is clear. A lot of inattentive symptoms. Maybe they have hyperactive symptoms or not. How do you usually treat? Let's say there's no depression, no clinical anxiety. Let's hone in on ADHD.
Certainly. So we already talked about kind of the non-pharmacological.
Yeah, let's talk about pharmacological medications that you use to treat ADHD. What do you turn to first line? What symptoms do you see that you want to choose this particular medication? Let's get into the nitty-gritty. A lot of people want to hear about the medications.
Of course. So when we think about medications, we usually think about stimulants and non-stimulants. So certainly, having a prior medical evaluation, or certainly for, adults and children, at least as a psychiatrist, knowing if people have any sort of underlying medical problems usually is a good idea. For example, cardiovascular health, having things like poorly controlled hypertension, high blood pressure can put people at risk for things like heart attack and stroke. We understand that stimulants may have a mild to moderate, risk of increasing blood pressure. So I essentially want to make sure that somebody may have, if they have any sort of concerns with cardiovascular health, that at least it's being addressed and it's being targeted by an internist, for example, family medicine physician, or a cardiologist.
Absolutely. So step one, you have your stimulant medications, you have your non-stimulant medications. When evaluating a patient for use of stimulant medications, like Pat is saying, the first thing is you have to make sure that it's safe. Now, stimulants may often increase resting heart rate by a few points a minute, but they can also have more substantial impact. So evaluating somebody's cardiovascular health and making sure that they are safe for stimulant use is paramount in choosing a stimulant. Yes.
And that's where I would start. And I think in many cases, many patients will prefer, perhaps do better on a stimulant-based medication, perhaps, than a non-stimulant-based medication. Again, I'll say, different things work for different people. Different people have different experiences with different types of medications. And, there is not necessarily a one-size-fits-all kind of process to this.
Of course. Now, let's say somebody comes in, no medication history, no cardiovascular issues, they're young, they're healthy. What do you turn to first? What helps you determine, well, first of all, what are some of the stimulant options? What are some of the non-stimulant options? And what determines which one you're going to choose? And assuming they have no history of substance abuse or anything like that.
Of course. So, certainly, two major classes, of stimulant medications. You have your amphetamine salts and you have your methylphenidates and other kind of derivatives. And many of those medications affect the brain by affecting the reuptake of neurotransmitter dopamine. Dopamine is involved in, many aspects of cognition, concentration, and can improve anything from, alertfulness, wakefulness, working memory, etc.
Motivated
behaviors in general, right?
Yes.
So oftentimes, I think, many psychiatrists find perhaps that, starting with the amphetamine salts, say, for example, Adderall, 5-ANTs, are, common strategies for many adults with ADHD symptoms. I'm not a child psychiatrist, but my understanding is that many child psychiatrists may prefer the methylphenidate, kind of formulations, as they, may have more shorter acting effects. They may impair less appetite suppression and sleep-related concerns. But it does seem like there are kind of two general camps that perhaps, pediatric patients may do better starting with the methylphenidate derivative, and adults, may do better with kind of an amphetamine salt.
Yeah, so we have amphetamines, your Adderalls, your Vyvanses. You have methylphenidate, which is your Ritalin, your Concerta, your Focalin. Now, both of these medications not only lead to a reuptake inhibition of dopamine and norepinephrine, they also cause a release of dopamine and norepinephrine. Now, reuptake inhibition, what does that mean? So the way your brain works, you have neurons, brain cells, they release certain neurotransmitters, dopamine, for instance. They get released, they're doing their work, they're causing a signal, an effect. Reuptake is when they're taken back up into the neuron, thus discontinuing their effect. So when you have a reuptake inhibitor, you're stopping the reuptake, which means the neurotransmitter, the dopamine, is there longer and has more of effect.
Correct.
So with amphetamines and methylphenidate, you're dumping your dopamine and norepinephrine, and you're preventing it from getting reuptook, aka stopping the action. So you release more, it stays around longer, and has more of an effect. Now, my understanding of the pharmacology, you'll let me know if you think, if you have a different understanding, is that the amphetamines have more of a balanced dopamine and norepinephrine effect, whereas the methylphenidate has more of a dopaminergic effect while also having norepinephrine. And in basic terms, now there's all sorts of other things these things are doing, like Pat was saying, but that dopaminergic effect is that motivated behavior to seek a reward. The norepinephrine, aka noradrenaline, is that arousal state. This is a very just basic way to understand how these neurotransmitters are working. They're also having much more complex effects with regards to executive functioning, working memory. But the amphetamines, dopamine, norepinephrine, more balanced. The Ritalin is more dopaminergic.
Agreed.
And oftentimes you'll find that norepinephrine bit has more of a edgy appetite reduction, more trouble sleeping. It's that arousal neurotransmitter.
And that seems why, again, the methylphenidate derivatives seem like they're more, commonly chosen for pediatric patients. Yeah, they're, I think, an easier starting point. And I think for many adults, they're looking for, something that will significantly reduce their symptom burden. And I find that, for many adults, starting with an amphetamine salt is generally very helpful.
Yeah,
certainly,
I agree.
Certainly it can make people anxious. Certainly it can suppress appetite. Certainly it can cause problems with sleep. But, many patients that, come to me with many of these symptoms are very impaired by the basis of, their, how these symptoms are impacting their lives, that it does come as a sense of relief that they can, function with a less degree of impairment or distress.
Yeah, and we're going to get to this a bit later, but what you'll find in the studies in the literature is that when a patient has bipolar disorder and they're prone to big-time manic episodes, the amphetamines are more dangerous to be used in this population as far as sparking off a manic episode, insomnia leading to a manic episode, than the methylphenidates for that reason. The methylphenidate, the Concerta, the Ritalin, the Focalin, is a more gentle stimulant.
Certainly.
Now, it's very dependent on an individual, but, the research shows is that Adderall and amphetamines are a great place to start. So when someone comes to you with ADHD, as far as choosing and selecting Adderall, how often is that your first choice? How do you dose it? Talk to me about Adderall dosing and how often that's your first choice.
Certainly. So, there's many formulations of the amphetamine salts. Adderall IR instant release, Adderall XR extended release, and certainly lisdexamphetamine, brand name Vyvanse, I think are perhaps some of the most common choices. We understand that certainly the IR formulation of Adderall,
instant release,
may be, higher risk of potential diversion, higher risk of recreational potential. So some psychiatrists may be more likely to start with an Adderall XR, the extended release formulation.
What does diversion mean?
So diversion is the process by which, say, for example, you go to a doctor, you're prescribed a medication. Instead of taking the medication, perhaps you sell it or you give it to somebody else.
It's more abusable. The Adderall tablets, the pills, rather than the capsule, there's more street value.
Certainly.
They're more abusable.
Certainly.
They hit quicker. You can chop it up. You can snort it. They're much more abusable. People seek them more often. Thus, they're more divertible, meaning they divert the prescription to somebody else.
Certainly.
Yeah. And lisdexamphetamine, aka Vyvanse, is the opposite of that. Can you explain to them what is Vyvanse and what makes it special?
So lisdexamfetamine is what's called a prodrug. So a prodrug means you take a medication and the medication itself does not work until it actually goes through your system of metabolism. So the lisdexamfetamine or Vyvanse capsule you take, and not until it gets into your stomach does it actually activate to the medication itself. So if people snort it, if they attempt to inject it, use it by other means, it essentially doesn't work. It doesn't provide a high. So perhaps it de-incentivizes, people using it for recreational value and perhaps has less risk, therefore, for diversion or for misuse than perhaps something like Adderall IR, the immediate release formulation.
Exactly. Lisdexamfetamine, Vyvanse, that has to be digested. It has to enter your bloodstream. It has to interact with red blood cells and the enzymes within red blood cells before it gets activated. So a lot of patients will notice that, hey, the Vyvanse takes a little bit longer to kick in. It's a little bit smoother of a come down, and it's absolutely less abusable than an Adderall instant release. Vyvanse happens to be my favorite amphetamine. But so what dosages, so what do you usually start? And how do you determine whether you pick an IR, an XR, an Adderall, versus a methylphenidate or a Vyvanse? How do you select what agent to choose?
Certainly. Well, first and foremost, I would probably start with a longer acting formulation of a stimulant.
Yes.
Because
Adderall XR or Vyvanse.
Exactly. So because people will feel, like you said, it's easier to come up, easier to come down. There's less of kind of a rapid onset of symptoms and kind of an after crash. So there is less a risk potentially for diversion and misuse. So I will typically start with Vyvanse or Adderall XR. There are times in which the longer acting formulations can cause problems with sleep, for example. So say, for example, people take their Vyvanse or their Adderall XR and the effects of the medication last for, a longer period than is desired. People aren't able to kind of calm down in the evenings, for example. They're not able to go to sleep at an appropriate hour. That might be an indication to consider instead an immediate release formulation, which essentially just has a shorter window of action.
Yeah. The IRs, the instant release, there's more flexibility. Hey, doc, sometimes in the morning I don't need my Adderall. I'm going to the gym. I'm not really doing anything that I need to be on Adderall for. But then again, my classes start at 1 p.m. If I take my Adderall XR, which lasts about 10 hours, I can't take that at 1 p.m. because then I'll have insomnia. So patients that want to have the flexibility of just 5-6 hours of effect, the Adderall instant releases are perfect for them. Patients that are burdened by having to take 2 pills every day and, hey, doc, I'm just working 9 to 5, I want action all day, are much better suited for the Adderall XR. They take it once a day, they forget about it. Now, how long do you find that Adderall XRs work? And do you ever run into problems with the effect, with the crash happening too soon? Like, hey, doc, I'm taking this 7 a.m., I'm crashing around 4. And how do you manage that?
I think for many people, the extended release formulations work for a standard workday. People are different. Sometimes people will experience crashes kind of, in the, mid-afternoon. That's certainly plausible. There are cases in which you may consider, giving somebody an extended release formulation to take in the morning and perhaps an IR or immediate release formulation of the Adderall, for example, to take in the early afternoon. And sometimes you can use that to kind of tailor, the medication regimen to, an individual's experience or their own reaction to the medication or their own, academic or, work needs, occupational needs. And you can make that work. And, different medications work differently for different people. And sometimes it's just a bit of a, I hate to say it, but a trial and error process where you start with one medication, you see how it goes, you feel this crash, maybe you add something else, you adjust the dose. But, an important part of it is an ongoing clinical assessment of how somebody's symptoms are impacting their lives and how these medications are essentially, hopefully, helping with many of these symptoms.
And that's our job. We're medication managers as well as psychotherapists. Trial and error. So what Pat was saying is, hey, This Adderall XR lasts about 8 hours. Hey, doc, I'm taking the Adderall XR at 7. I'm crashing around 4. I'm crashed after work. I have no motivation or mood to socialize after work. What am I going to do about this? And what Pat was saying is that we often add in an Adderall instant release booster to take about 1 hour before you feel the crash. I take my Adderall XR around 7:30. I take my Adderall instant release booster around 3 p.m. That way, I push the crash to about 8, in which it just bleeds into when I'm asleep. That way I can maintain my motivation, my mood, my energy, even after work when I want to socialize, go to the gym, whatever. That is classic, because people that have ADHD, they have it all day, right?
Correct.
And we don't want to interrupt their evening or their early evening or late afternoon with a crash. So it is common practice to add in an Adderall instant release booster. So instead of just that 8 hours of effect that you get on XR, you now have 12 hours effect of Adderall, so you can not be crashed in the evenings. How often do you see in your patient population that a booster is needed?
It's variable. I think it really depends on the patient. Sometimes we'll inherit patients. I will have patients come to me that have already been taking several medications. They have a sense of what already works for them. Sometimes people will come to me, and they've never taken a stimulant medication, and we're starting from scratch. But with time, I think you have a sense of what works for different people. I think ideally, I would always just start with one medication and kind of see how people do, assuming if they're, de novo, they have not, had treatment before, the treatment naive, as we sometimes call it. But sometimes, just hearing from the patient, their own experiences and what works for them, assuming it's, within the, scope of what's appropriate and what's evidence-based, can be helpful to help tailor a treatment plan for people.
Yeah. What's the average effective dose of an Adderall XR generally?
So it depends on, the age of the patient, the weight of the patient, health risk factors of the patient. I would consider anything from, probably 10 milligrams to 40 milligrams, doses as high as maybe 60 milligrams, maybe higher, may have benefit, may be indicated. I think with many of these medications, I would probably start, for example, on the Adderall XR, 10 milligrams or 20 milligrams, kind of see how people do and kind of, adjust it accordingly. So certainly, some people are more conservative in their dosing. So, by being more conservative, you may have fewer effects on, appetite or anxiety or, insomnia, but you may not treat the cognitive symptoms. And the opposite may be true by kind of being a little more aggressive with the dosing. You may, treat people. So sometimes, giving people, my own patients, some flexibility with, the medication regimen, maybe try 10 milligrams for a week, and if it's working, great. If it's not working, consider 20 milligrams and we'll take it from there. That might be where I start. Similarly with like a Vyvanse, I probably would start at 20 or 30 milligrams, typical ranges, maybe 20 to 70 milligrams once daily on those medications. But everybody's a little bit different, I do try to tailor it to the patient and, give them some options and a sense of stake, in their own treatment.
Yeah, absolutely. Typically what I see is the same. The minimal effective dose of Adderall XR is usually between 10 to 20. The vast majority of my patients, once they get to Adderall XR 15, hey, doc, I feel it. Now, what do you say to patients that get rapidly desensitized? Dr. Baumgart, yeah, this Adderall XR 20, it's wonderful, amazing. They come back in a month, it's not working that well. Bump them to 25. Hey, doc, it was great, amazing. Come back in 6 weeks. Hey, doc, it's not working that well. How do you handle patients that are getting desensitized to their amphetamines and stimulants that keep requiring dose escalations? How do you deal with that?
So I think a very good question, and I think there perhaps are a lot of different considerations that come to this point. I would try to get a sense of, are people taking this medication every single day? And if they are, perhaps there are opportunities to go days without the medication, what we call drug holidays.
Yes.
And these drug holidays, days in which perhaps that I don't have the same, school responsibilities or work responsibilities, perhaps I can go without the medication. That may prevent the likelihood of, rapid sensitization to, the medication, desensitization to the medication. So that may be a helpful strategy. A second consideration may be placebo effect. Sometimes people, when they start medications or they change medications, they may misappropriate good things that happen to them or doing well as an effect of the medication, when in fact it may not be due to the medication. And maybe after a few weeks where, this wears off, people may be less likely to report benefit from the medication. And perhaps the third thing that may come to mind in cases like this are cases of misuse or cases of malingering or cases of diversion. If people are asking for rapid up-titration of medications or use of medications in a way that is not, clinically appropriate, evidence-based, I might wonder about that in certain patient populations. Certainly, I want to give everybody the benefit of the doubt. I want to trust everybody who walks through the door. My first goal is to do no harm for any patient and to honestly improve, the likelihood of, giving people the tools they need to be successful in their lives. But unfortunately, in some cases, that does come up. So I think with stimulants, that is something that, is often on our radar, something that, we need to be honest with our patients about. We need to be honest about kind of the controlled nature of these medications by the federal government and kind of mandates for state reporting systems. And I think there are a lot of considerations that come up in cases like these.
Yeah, I think that's a great point. Now, these medications, like Pat was saying, are controlled. The biggest risk with Adderall and other stimulants is the risk of dependence. Now, when patients come to me requiring higher doses, doc, I don't feel it, I also ask them, which effect of the medication do you feel wearing off? Is it the arousal and the energy? Is it the ability to start tasks? Or is it that somewhat euphoric mood elevation that you get from the medication? Now, if they're telling me, hey, doc, the euphoria is wearing off, then we have a whole nother conversation, because the goal of the drug is not to cause euphoria. So if you're chasing that euphoric feeling you had when you first started the Adderall, then we need to have a conversation that that is not the goal. That is not sustainable at all. And then we also have to then talk about if it's the elevation in mood that you feel like you're chasing with requiring higher doses, what is going on with the underlying mood? Is the Adderall just masking some sort of mood disorder like a depression? And how else can we get to that? And is also what you said, can we take some drug holidays? And another pitfall that ADHD patients on stimulants fall into is utilizing the medication to replace self-care. You always have to get appropriate sleep, 7 to 9 hours of good sleep overnight.
Correct.
You always have to eat well, drink enough water, get sunlight, get exercise. At no point is Adderall a replacement for self-care. And if you are using this to push through fatigue of poor sleep, all that's going to do is make you feel like the medication is not working well enough, and it's going to burn you out faster. So I also start asking about these self-care routines and regimens and how are they sleeping and all the rest of it. Because an Adderall taken after a night or several nights or weeks of poor sleep is not going to feel as effective as an Adderall taken when everything else is in place, including appropriate sleep.
And I think that's critical, ensuring, appropriate sleep hygiene, giving people the skills to, live their lives in a way that's healthy and constructive.
Yeah.
Going to bed at the same time every night, waking up at the same time every night, limiting use of other stimulants, limiting use of alcohol and marijuana, for example, before bedtime, which may help effectively sedate you, but may impact your sleep architecture and your ability to get restful sleep. All that is critical. Ensuring that people are getting appropriate physical exercise, that they're engaging in wellness, that they're engaging in appropriately hobbies and other things that, bring them a sense of joy and wellness. It's not a panacea. It's not a fix-all.
Absolutely.
And I think having, a sense of that as part of the treatment plan, not the entire treatment plan, is an important conversation to have up front with people.
Yeah. Now let's get into some nitty-gritty. So here we have two psychiatrists that are working every day with patients, evaluating and treating ADHD. Now let me ask you some questions. We'll compare strategies here. So oftentimes you see that the stimulant is highly effective, but it's a little too edgy. Hey, doc, I'm getting a little sweaty. Hey, doc, I'm getting a little bit anxious. Hey, doc, my heart rate is elevated a little bit. Do you have other medications that you will mix in to soften the stimulants?
Certainly. And I think this is an argument, potentially for the use of non-stimulants. This is potentially an argument for, the non-medication methods such as CBT. This is potentially, an invitation for, just good hygiene in your sleep and your exercise and your other matters. In patients that have kind of residual symptoms, by that I mean, it's treating some of their symptoms, but they're having some side effects from their stimulant.
Yes. Stimulant's great. I'm having side effects. What are some augmenters or medications that you might add on to soften it?
Sure. And some of this depends on, if people have other symptoms of other disorders, things like anxiety disorders, things like depression or other mood disorders. If people have substance use disorders, certain, disorders may kind of bring me down the track to consider certain medications. Some things that can be helpful, certainly some antidepressants may be helpful for ADHD. Certainly a class of medication called alpha-2 agonists, which are traditionally blood pressure medications, but things that can reduce kind of what we describe as central hyperarousal in the brain can be helpful for patients. And other non-stimulants, things like Strattera, for example, atomoxetine, can all be, effective strategies that you can add on. Certainly if people have, underlying anxiety disorders or mood disorders, the use of an antidepressant, SSRI antidepressant may have some benefit as well. There are really a lot of options out there that you can tailor to your patients.
Now, this is a tip, not just for patients, but other providers out there. I'm working with patients like this every day. Alpha-2 agonists, guanfacine, for instance, is a very useful medication to augment stimulants and also, by the way, treat anxiety. Now, how do alpha-2 agonists, how do those work, and how do they potentially soften or augment stimulants in ADHD?
So the alpha-2 agonists work within the brain, again, to kind of promote a sense of calming down what we describe as central hyperarousal. So essentially it impacts the brain in a way that can reduce anxiety, it can reduce a sense of alertness, it can reduce a sense of edginess, that can help people, help mitigate some of those symptoms that you may see with a stimulant.
What's an alpha-2 agonist? You can get a little bit detailed. What is an alpha-2 agonist?
So traditionally it's used as a blood pressure medication. We use them in a wide range of psychiatric illnesses, not only ADHD, but also other things like other neurodevelopmental disorders, such as impulse control disorders in children, for example. They can help people mitigate their irritability, their kind of emotional dysregulation, for example. They can help people just kind of feel calmer in general.
Now, your alpha system, it's your alpha adrenergic system. It is where adrenaline and noradrenaline can bind onto those alpha receptors, causing a variety of, feelings or symptoms or effects. Hyperarousal, like you mentioned, constriction of blood vessels. It can also... It helps soften stimulants because it can help kind of relax the body while a stimulant who is kind of tensing the body is in effect. The last thing we want to do to treat anxiety or tension when someone is on an Adderall or another amphetamine or stimulant is add on a benzodiazepine like a Klonopin, a Xanax, or an Ativan.
Agreed.
Full stop there, right? Do you ever concurrently use standing, meaning scheduled and daily stimulants on top of benzodiazepines?
I would argue that that's poor form.
Yeah.
Certainly there are many patients that, may come to me and they've been taking both medications for years. Generally, I would argue against it, and that would not be concurrent with my own prescribing habits. I would not start people on both of those medications. I would argue that certainly a stimulant and a benzodiazepine are essentially having contradictory effects to one another. So certainly the stimulant may help people with things like arousal, wakefulness, concentration, the ability to complete oriented tasks. And stimulants, on the converse, may impact things like worsening anxiety and sleep. Unfortunately, benzodiazepines tend to do the opposite. So benzodiazepines are a class of anxiety medications that essentially work on the GABA A receptor in the brain, similar to alcohol, barbiturates, other sedatives that can help calm people down. They essentially can promote sleep. They can promote anxiolysis, resolution of anxiety is what I mean by that. But they can certainly impact things like your ability to concentrate. They can cause what's called anterograde amnesia, where people essentially have difficulty remembering things that happen after they take the medication. Blacking out, as we all have, perhaps heard of or experienced from alcohol or other sedative hypnotics. So I would argue that it's not good for them to have people on both medications. And
I agree. That's a golden rule of psychiatry. You never want to use concurrently amphetamines or other stimulants and benzodiazepines. Now, if you're looking for ways to soften the stimulant, hey doc, I have ADHD, I don't have an underlying clinical anxiety, but I'm getting anxious and too aroused with the Adderall, but I can't go on a lower dose, like Dr. Baumgart was saying. So there's other options. There's alpha modulators like your guanfacines. There are beta modulators, your beta receptors like propranolol and atenolol. Some people like to use gabapentin, which I'm not usually my first choice. But there are ways to soften the stimulant effect outside of using benzodiazepines when you're on a good dose of a stimulant that you cannot reduce. Now, anything else as far, now let's talk about the non-stimulant options as far as Wellbutrin and Strattera. So what are Wellbutrin and Strattera? How are they used in ADHD? And how are they different than stimulants? And are they as effective?
Of course. So again, I'll start by saying, I don't think there's a single medication that works well for all people. People are different, inherently in their symptoms and their tolerability to medications and how they respond to medications.
Of course.
Wellbutrin, or brand name bupropion, is a class of antidepressants. It's what's called a dopamine norepinephrine reuptake inhibitor, which essentially prevents the reuptake of those neurotransmitters, those chemicals, dopamine and norepinephrine, in the brain, essentially shutting off kind of the recycling of it. Exactly. So Wellbutrin is an antidepressant. It is something that I think specifically for symptoms of depression and ADHD can be helpful. It can give people a sense of energy, a sense of motivation, can help people perhaps with a goal-oriented behavior. And it is not classically, a stimulant, and it can help also. Its primary indication is to help with mood disorders, and it also is marketed for tobacco use cessation, for example. So if you have somebody who comes to you that may have, ADHD, and we know that, mood disorders are comorbid, meaning that, it's common that people may have mood disorders and ADHD in tandem. And if they're, smoking cigarettes or using other forms of tobacco, vaping, for example, it can be a very helpful agent and something that may be safer from, a cardiac standpoint in patients that have, uncontrolled high blood pressure, other cardiac illnesses. And it may be a good catch-all if you have patients with kind of all those symptoms as well.
Yeah. And not sorry to interrupt, but there's also much less of a risk of dependence
Correct.
with Wellbutrin than Adderall. Wellbutrin is not a controlled substance. It operates on the same neurotransmitters as Adderall, dopamine and norepinephrine. It is strictly a reuptake inhibitor, so it's not causing any sort of release. And there are excellent trials, plus double-blinded, placebo-controlled trials of using Wellbutrin as a single agent to treat ADHD that shows that it is much more effective than placebo. So the ideal candidate of, okay, I'm somewhat depressed, I have ADHD, I'm trying to get off smoking, 3 birds, 1 stone. But Wellbutrin can be used as a single agent to treat ADHD without the risk of dependence. Mind you, it's less potent. You might not feel that switched on, I'm ready to go feeling like you do with an Adderall, but it is still an excellent option as a single agent to treat ADHD without any sort of risk of dependence. So we've talked about stimulants, we've talked about non-stimulant options like the alpha modulators, we've talked about Wellbutrin, Strattera, atomoxetine is another Wellbutrin type medication. It's a dopamine, more so a norepinephrine reuptake inhibitor. But let's get into bipolar, characterizing what is bipolar. We'll talk a bit about the medications, and then we'll talk about the overlap of ADHD and bipolar and how people can get misdiagnosed, and comparing hypomania, mania, that hyperactivity, impulsivity, distractibility, and how to contrast that with ADHD. And then we'll take some audience questions. How does that sound?
Sounds like a plan.
Bipolar disorder, what is it? How do you diagnose it? What is bipolar disorder?
So bipolar disorder is traditionally classified as a mood disorder. And as a mood disorder, people will have both symptoms of depression and what's called mania or hypomania, which is kind of a milder version of mania. Basically, people will, those are the 2 poles, as we talked about earlier. People may have periods where they have, feelings of sadness, sleep disturbances, inability to feel pleasure, feelings of hopelessness, poor energy, poor concentration, appetite, thoughts of suicide. Depressive episodes is what those are, that may last for weeks or months if untreated, maybe even years in some patients. And then the other side of the coin is these manias or hypomanias. So people may have periods of times, and it's always important to determine during periods of sobriety if this occurs.
Absolutely.
That people have episodes of decreased need for sleep for days at a time. And by that I mean, has there been ever a time where you were able to stay awake and not have to sleep for days at a time, more than 3 days at a time, more than 5 days at a time, as long as an entire week at a time, and not feel tired? So, and I think that's kind of the ultimate confounder. A lot of people will have insomnia, sleep disturbances. A lot of people will have periods where they want to sleep, but for these episodic decreased need for sleep, there is no desire to sleep. And during these periods of time when you're not sleeping, there is unusual irritability. There's unusual euphoria. By that, I mean you feel you're on top of the world. There is unusual productivity. For example, I painted the entire inside of the house in a weekend. There is unusual risk-taking behavior, spending large sums of money for people that typically would not spend, having sex with many people, assuming that's not kind of your typical behavior, aggressive speeding. And oftentimes during periods of manias, people may find themselves in circumstances that get them into a lot of trouble. For example, I spend my entire life savings in a month, or I got pulled over and got arrested for speeding. Or perhaps, I had a lot of, conflicts with those people around me, and I've had deficits in my relationships, or a lot of fallout from my relationships. So that's what true bipolar 1 is. People with bipolar 2 is a bit of a, kind of a milder version of this illness. They have hypomanias rather than manias. So they can have these periods where they're not sleeping well, but it may be less impairing. And in fact, people during these periods can be, very productive and not get into trouble. So they may not come to the attention of a mental health provider.
Yeah. Now, what Pat is saying, bipolar disorder is a mood disorder and is episodic. We have majorly depressed episodes, and we have incredibly heightened episodes that we call either hypomania or mania. Decreased needs for sleep coupled with an increase in energy, increase in goal-oriented behavior. We might be talking at a faster rate. We might be taking risks we otherwise wouldn't be, acting impulsively. And it's a mood episode at its core. So we have this fixed mood, this euphoria, elated sense of gratitude, this irritability. And one way to distinguish that it is a mood episode is that it is oftentimes fixed. So I am euphoric, I'm grateful, I'm getting all this bad news, I go to a funeral, this didn't go my way, and just finding and maintaining this like episode of heightened mood. It's a fixed mood episode. Oh my God, I feel so connected to everybody. I don't need to sleep. There's not enough time in the day. I'm running on 8 cylinders. The rest of the world is running on 4. Nothing can stop me. And that's what we call a mania or a hypomania. Now, patients always ask me, especially when they're hypomanic episode where their functioning is elevated, their judgment is intact, they're not getting themselves into trouble and their functioning hasn't deteriorated. Doc, why would I ever treat this hypomania? Why? Why would I take pills to try to dampen out this amazing feeling? I'm depressed for so much of my life. Why would I try to treat this period of intense elevation? It's not a problem. It's not manic. Why would I treat my hypomania? What do you respond? How do you respond to these patients as far as treating their hypomania?
And I think that's often challenging.
Yeah.
Because when people experience their hypomanias, they're productive, they're feeling well, they're, doing well, for example, staying up all night, reading all this information, doing well in their classes, despite working during the day, they're achieving all these other products. So it doesn't come at an expense. So I think many people, would question, why is that something that is problematic? Why is that something that warrants treatment? And I guess the larger question is, at what point in time does it become impairing of your function? At what point in time does this behavior get you in a bind? It gets you in a risky situation that causes downstream damages. And that is, I think, always a risk factor for somebody with a hypomania, that they may have a period that does result in a degree of damages.
Right. It might develop into a full-blown mania.
Agreed. And sometimes, while we think of bipolar 1 as being the more, severe version of such with true manias that cause damages, and bipolar 2 being that doesn't, people can certainly bleed between different categories. And I'm not one to believe that there is, necessarily a concise difference between, both of those illnesses. So that would be kind of a first thought, is I would encourage somebody, listen, there may be a period where you may have a hypomania that, you may engage in behavior that does cause problems, and what I, additionally would consider is, many of the treatments for bipolar disorder, they not only help with, the problematic, risky behavior and damages of mania, but they also help prevent those, those depressive periods that can be very painful to people.
Bingo. Yeah. Now, I would just echo what you said. Doc, why treat this hypomania? I'm feeling so great. Well, Jimmy, first of all, we don't know if it's going to lead into a destructive mania that might cause major problems in your life and the lives around you. And 2, if we treat the ups, that helps reduce the chances of going into a major low subsequent to that elevation. Correct. Those are also my 2 main answers as to why I treat a hypomania. What are some, and as far as medication management for bipolar disorder, let's say you have a good diagnosis, this person is bipolar, I've differentiated between their depressions, their baseline, and their hypomanias I'm going to treat. What are some medications that you often use? I get it's individualized per patient, But what are some of the most common medications, most effective medications you use in bipolar?
So there are many. And again, I think what you're saying, ensuring that this is an accurate diagnosis is paramount. That's fundamental.
Of course.
So there's a lot of misconceptions, again, in the lay culture about what bipolar disorder is, people that are always irritable, people that are unreasonable perhaps, and very much this is not what that is. Looking for episodic nature of symptoms, like you said, where people are unusually irritable during times of feelings of sadness, depressive episodes, or during these manias or hypomanias is important to discern. And secondly, does this happen outside of the context of stimulant use, cocaine use, methamphetamine use, phencyclidine use? All these things can mimic or look like manias, and that's important to exclude.
Absolutely.
So coming back to the question, coming back to the drawing board, assuming you have made an accurate diagnosis of bipolar disorder, there are several classes of medications that can be helpful. First and foremost, we think about mood stabilizers as being, potentially something that is very helpful. A mood stabilizer, some examples include lithium, include valproic acid or divalproic, sold under the brand names of Depakote or Depakine, also carbamazepine, lamotrigine, oxcarbazepine, for example, essentially help prevent the highs of manias and they help prevent the lows of depression.
Yeah, and I think what's important to know is that mood stabilizer is a class of medication in which there's medications that have completely different mechanisms of action. So Depakote, for instance, versus lamotrigine versus lithium, these three are all working in different ways as far as like the mechanism of action, but they're all serving as a mood stabilizer. Now, in bipolar disorder, as far as just using one agent, that is usually the exception to the rule.
Correct.
What I have found and what the literature shows is that typically we need more than one medication in bipolar. We usually need something that's called an anti-manic agent, something that prevents the elevations and the manias. And oftentimes we need a bipolar antidepressant as well. Do you find that usually you might need combo therapy when treating bipolar, or have you found that you're able to successfully treat with just one medication?
I think typically it does require combination treatment. And some of it is the degree of which, somebody's symptoms are impairing a functioning. Is this a true bipolar 1, that may, risk getting somebody, in a psychiatric hospital or in jail or in significant trouble? Or is this, a less, severe variant where people may just have significant outbursts with, their spouse, for example, or their boss or their parents, and it may cause significant problems in their interpersonal life, but they're able to maintain a sense of, function in the workplace, financial stability and housing stability. And some of it is just, when you catch, somebody in the course of their illness, if you catch somebody in a depressive episode, if you catch somebody during a mania, you may be more likely to select one agent over another.
Absolutely. Now, let's say somebody has bipolar as well as ADHD. Now, shortly we'll get to the overlapping symptoms, how to tell the difference, but let's say someone has both bipolar and ADHD, which happens frequently. Can you use stimulants to treat ADHD in a patient diagnosed with bipolar?
You can. It is something that potentially poses a risk and something that does require careful consideration. Certainly the use of a stimulant may predispose somebody to developing a mania or a hypomania, similarly to how the use of in patients that have bipolar disorder could be at risk if they were to use other stimulants, recreational stimulants, for example, things like methamphetamine, things like cocaine, phencyclidine. So certainly is something we can consider and is something that is often, a point of perhaps some source of, some degree of controversy. But as we discussed earlier, the amphetamine salts may pose a higher risk of, precipitating a mania than something like methylphenidate, or certainly something like a non-stimulant ADHD medication.
Yeah. And it's important to know that if you have bipolar and ADHD, we certainly can treat the ADHD. Now, if we're entertaining the idea of stimulants or anything stimulating at all as far as treating the ADHD, You must be adequately mood stabilized.
Critical.
Meaning on a therapeutic dose of lithium or whatever mood stabilizer you're on, before the conversation can even be had, am I going to utilize a stimulant for this ADHD? Now I'll talk just from my own practice. If I have someone who has had destructive, life-threatening, really dangerous manias, and if they get psychotic during their mania, 99% of the time I will not use a full-blown stimulant. If someone has bipolar 2 and they have not had super destructive, functionally impairing, and dangerous manias, I might be a little bit more comfortable using stimulants. And what we discussed in the past is if you are going to use a stimulant in a patient that has both bipolar and ADHD, the research shows that methylphenidate, aka Ritalin, Focalin, or Concerta, has less of a risk of pushing someone towards a mood episode than the amphetamines. And again, in patients that have both, you might want to start with a alpha modulator like guanfacine, aka Intuniv. You might want to start with a Wellbutrin or a Strattera that's not a full-blown amphetamine. So really, you have to exercise so much caution in bipolar patients in treating their ADHD, even if they are mood stabilized.
And I think that's critical. And I think coming to a degree of diagnostic clarity is really important in many of these patients. So again, people come to you with a lot of complaints about, concentration. I think it's important to acknowledge that there are many things other than ADHD that may cause difficulty with concentration and completing tasks. Certainly depression can, certainly anxiety disorders can, certainly during periods of manias, people may be, very disorganized in terms of their behaviors and their ability to do such. So presuming that is the case, presuming you have somebody who does have bipolar disorder and does have ADHD, ensuring they're adequately mood stabilized is critical. And by that, we mean being on a therapeutic dose of a mood stabilizer, as we've discussed. Also, antipsychotics can be helpful, also known as neuroleptics. There are medications that can treat psychosis, but there are also medications that can help the lows of depression, the highs of mania, medications like quetiapine, brand name Seroquel, lorazepam, brand name Latuda, aripiprazole, brand name Abilify, to name a few are examples that can help people, attain a degree of mood stabilization that can help prevent against the risk of an ADHD medication kind of worsening their symptoms of mania.
Yeah, and what Pat was saying, there's a lot of things in bipolar that can mimic ADHD. If someone is in a clinical major depression, a lack or difficulty concentrating is a hallmark feature of major depression. When someone is manic, they get hyperactive, they get impulsive, they get distractible. That is a hallmark feature of mania and may not be ADHD. Now, if I were to choose what is the biggest differentiator between ADHD symptoms and, hey, is this bipolar? Is that bipolar episodes are episodic.
Correct.
If they are hyperverbal, butting into conversation, distractible, cannot concentrate, fidgety, can't sit still, as far as like a bipolar mania or hypomania, that is an episode. Also, what you find to differentiate bipolar mood episodes from ADHD is the mood component. There is a fixed clinical mood, whether it's majorly depressed, hyper-irritable, super euphoric, that you don't see in ADHD. ADHD is not episodic. There's not some sort of clinical fixed mood disorder accompanying it. And it's pervasive usually in somebody's life. Again, the episodic nature of bipolar and the accompaniment with a mood episode is two of the biggest ways I differentiate between, are these ADHD symptoms or is it secondary to bipolar?
And that's critical. I think differentiating, something that is chronic in nature. I always have problems with, impaired concentration, organization, completing tasks. I always have, hypersensitivity to, negative appraisal or judgment by other people. Or during this period where I'm feeling significantly sad or significantly energetic or euphoric, is that unusual in nature? I think is critical to determine.
Yeah, absolutely. So if you feel like you have ADHD or bipolar or both or anything else, it really behooves you to sit down with a skilled psychiatrist who can get some diagnostic clarity. Now, I know this isn't available to anyone. Unfortunately, finding and sitting down with a good psychiatrist that cares, that is competent and educated and can sift through these nuanced differences is a luxury. I recognize most people don't have that luxury, but you really, really need to get diagnostic clarity, because being misdiagnosed as either can cause significant problems in one's life.
It certainly can, and ensuring that before, a psychiatrist prescribes a medication, that a diagnosis is accurate is critical. And certainly many people will come to me that have been on medications, have prior diagnoses, that, don't make sense or are not accurate, medications that are not helping them. And at times it may be important to go back to the drawing board and really carefully consider. And I always encourage, as people, come in for an assessment for, symptoms of cognition, that, a lot of people come into the conversation with, some biases, perhaps with a preconception, with a notion, with a prior diagnosis. And sometimes it's important to harbor a sense of uncertainty is important, or
Absolutely.
uncertainty is necessary.
Uncertainty, curiosity, I'll speak for myself, I will rarely ever just accept a prior diagnosis the patient is entering my visit with. It is our job to do our own evaluation and assessment and get diagnostic clarity as to what is going on.
Agreed.
Yeah. Now, let's turn to some audience questions. Okay, this is a question I receive all the time. If I have a loved one who is in a manic episode and has no insight into the fact that they are currently sick and in an episode, and is engaging in destructive behavior and jeopardizing his own life and the lives of others, how can I get this person help?
And I think that is one of the hardest scenarios for a loved one to be in. You have this person that you care about so much. You clearly see concerns. There clearly is a huge discrepancy in terms of the way they feel versus the way you feel. In cases like this, I think it is important to get people immediate help. You can certainly call 911. You can certainly take somebody to the emergency room, make sure they get, an urgent psychiatric evaluation. And this can be very painful for many loved ones because, certainly if, the patient objects, if they don't feel the same way, it can be very, very delicate to encourage them to see a doctor when they don't want to. But on the converse, what I can say is, many people, when they're in periods like this, they do engage in behaviors that, are very permanently damaging. In many patients, when they're helped through these periods of time where they're brought to the hospital, where they're offered treatment, when they accept treatment, many people do improve. Many people do get much better. And sometimes it's not until somebody gets much better that they realize how sick they very much were.
Yeah. It's a very difficult situation because oftentimes the family and friends, they feel helpless. And unfortunately, there's a lot of times where there's no helping this person. They are so convinced, they're so out of touch with reality. They can't accept when you show them evidence of the problem and the damage they're causing, that unfortunately, a lot of times you just have to wait for the mania to get extinguished and the damage has already been done. But like Pat was saying, even if you have to involve emergency services, because this is an emergency, people can engage impulsively, they can have a big increase in their tolerance for risk, and they can, their life or livelihood can be in jeopardy.
Certainly.
But it is amazing how effective medications can be in treating acute mania. There is absolutely hope that if you involve emergency services, which can be very difficult, of course, that once medicated, even in a few days, let's get him sleeping, let's get a mood stabilizer in him, let's titrate it up quickly, let's get him into some sort of safe environment where he can't jeopardize his or other people's lives or her, that there is absolutely hope that this can be managed and treated in the acute setting. But the barrier there is getting the person to accept treatment. And if you have to involve emergency services and perhaps treat them against their will, despite the acute pain and you feeling like you might be betraying your loved one, that can literally be a life-saving approach.
And it often is critical, and if you find yourself in a situation where, yourself or a loved one is in the scenario where, you have symptoms of a clear mania, you're spending large sums of money, you're engaging in self-injurious behavior, assaultive behavior to others, or acting in other ways that are damaging, it is critical to get help immediately.
Absolutely. Can someone with bipolar disorder be treated with classic antidepressants like SSRIs?
They certainly can, and oftentimes people are. So you mentioned before, many people with bipolar disorder may need multiple medications to manage their symptoms, whether it's a mood stabilizer that helps kind of keep people in states of euthymia. By that I mean places where, you're not manic, you're not hypomanic, but you're not depressed. That can be critical. Antidepressants are helpful in terms of helping people through the lows. And some of the antipsychotics may be very necessary to help people through periods of manias, especially when they have symptoms of psychosis. If they develop false thoughts about things that are not going on, if they develop perceptual disturbances, hallucinations, by that I mean hearing voices, seeing things that are not there. If people are, developing significant feelings of fear and isolative behavior, there is a place and time potentially for all these classes of medications. We know that many people with bipolar disorder unfortunately spend many of their episodes with depressive symptoms. And traditionally there is a fear that using antidepressants alone may risk somebody precipitating a mania or a hypomania. Certainly not to the same degree of using a stimulant medication for ADHD, but we still see that as a potential risk. So usually what is considered good form is to have somebody adequately mood stabilized, whether that's by lithium, any of the anticonvulsants such as valproic acid, lamotrigine, oxcarbazepine, carbamazepine, or an antipsychotic at a good level before you add the antidepressant. And having an antidepressant, in addition to these medications can be tremendously helpful for many people and is something that is, certainly within the scope of what is good care.
Yeah, and I would agree with you. If a patient has bipolar, and the literature supports this, certainly, I would not introduce an unopposed SSRI, meaning this person has bipolar, let me treat the depression with the Prozac, Zoloft, Lexapro. I would never do that. The evidence shows that that can be damaging. It can cause turbulence in mood. If you have an adequate mood stabilizer on board, meaning one of the medications you mentioned at a therapeutic level, then you can bring a traditional antidepressant like an SSRI or Wellbutrin and hope and expect that it might be therapeutic and helpful. So if you have bipolar, can you use antidepressants? Yes, but you want to be adequately mood stabilized before you bring it in, or else you're going to risk turbulence in mood. And there's actually, as far as I know, no evidence for treating major depression in a bipolar depression with an antidepressant like an SSRI unopposed. You always need a mood stabilizer on board.
Yes, and that's typically, good form. And I think oftentimes it can be challenging to make the diagnosis again of bipolar disorder, because maybe people will come to you with symptoms of depression and maybe their symptoms of hypomania won't be identified or won't be reported, or there may be a narrative of, significant, stimulant use. So sometimes it can be really challenging if you don't see people during their periods of their manias, or if you don't have, a clear sense of their history. Sometimes people are not very good reporters. clues of their own symptoms historically, and sometimes you just don't know.
Yeah.
So it can be challenging, but when in doubt, I think if you suspect that somebody, may have a bipolar diathesis, by that I mean historical symptoms of a mania or hypomania, is to get them in a place where you adequately mood stabilize them first.
Yeah. And the challenge with bipolar is that, I forget the exact number, but a large percentage of patients that have bipolar are misdiagnosed for like this first 6-7 years, because what's most prominent is the clinical depressions.
Certainly.
They have their hypomanias, but it gets confused like, hey, doc, I was just not depressed. I was so happy things were going right and I wasn't depressed, so I was functioning super well. It gets classified as a major depression, not a bipolar depression. They get treated like they have unipolar depression, so major depression rather than bipolar depression. And it's not until later where a mania or a hypomania presents itself in an obvious way that they're actually able to be confirmed and diagnosed with bipolar and treated accurately. And so that is the challenge, is that oftentimes it takes years to accurately diagnose bipolar, because what has been most evident is the major depressions, the hypomanias just get brushed off like, hey, doc, I'm just not depressed. Things are going well. I'm doing super good and I'm super functional. But it's not until later where the mania or the hypomania presents itself that you can diagnose accurately and then treat accurately.
And that's often a clinical consideration. I think it's good form for anybody who, potentially is starting on a, traditional antidepressant, anybody that I'm seeing in the office and you presume they have a unipolar major depressive disorder, is that you do caution them, about some of these symptoms. If you experience, periods where you're not sleeping well for days at a time, if you're not feeling the need to sleep, if you're feeling unusually irritable or euphoric, if your friends are commenting that you're talking a lot, if you're engaging in unusual risk-taking behavior, if you're unusually productive, these all could be warning signs. I think that is an important conversation to have, off the bat, and give people a sense of, what kind of symptoms they should be, kind of keeping in mind.
Absolutely. Okay, Dr. Pat Baumgart, thank you so much for joining us. We'll bring you back. If you guys want to hear more about ADHD, if you want to hear more about bipolar, if you want to hear more about the medications, dosages, whatever you guys want to hear, let us know in the comments. Thank you so much for joining us.
Thank you, Dr. Ma. It's been a pleasure.